Good afternoon, everyone, and thanks for joining in. It looks like people are creeping in today, but we expect quite a lot of viewers for this really important and timely talk. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's virtual Grand Rounds, hosted by California Health and Human Services and the California Medical Association. This Grand Rounds is a special one on our calendar. We actually put in an extra one because this topic is so timely and important, and it's called A Year at Home, School Reopenings and Pediatric Mental Health and COVID-19. Next slide, please. These are our speaker disclosures. Next slide, please. And some titles of our speakers and our agenda. Next slide, please. And just a reminder that CME is being provided, so you'll be sent a survey after the completion of the webinar. Make sure to fill in that survey to attest your attendance, and then we'll send you your certificate for today. Next slide, please. So we feel, or I certainly do as a pediatrician, that school closures have devastating consequences for children's learning and also their health and well-being. And what we're seeing in the healthcare system is really just the tip of the iceberg of the physical and mental health consequences of COVID-19 in our children. My 8-year-old daughter actually asked me just the other day, "Can I go in my friend's house unmasked, please? This is what childhood is about, Mama." And I'm missing my own childhood. I'm not making this up. She really said that. So even if we're not seeing them in our offices and our hospitals, our kids are feeling it. In fact, I really believe that we're in the midst of an under-recognized public health crisis for our children due to the COVID-19 pandemic. At the height of national and local lockdowns due to COVID-19, it's estimated that 1.6 billion children were affected by school closures. The world's come a long way toward reopening schools since then. According to UNICEF, 888 million children still face significant disruptions in their education due to full and partial school closures. And schools for about 168 million children have been closed for more than a year now. The Americas, in fact, are the very last in the world to reopen schools. 2/3 of the countries with persistently closed schools are in the Americas. And according to UNESCO data, US schools have been closed on average of 47 weeks. China and Australia, 27 weeks. In France, the schools were closed for 10 weeks. California, a leader in so many ways, is dead last in America, number 50 out of our 50 states. There are 6 million California public school kids and over 1,000 school districts, and a vanishingly small number of these are back in school. Many, if not most, of the approximately 500,000 students enrolled in private schools are back in school. California also has the distinction of having the highest rate of youth poverty and one of the lowest rates of per pupil funding in our country. The COVID-19 pandemic has highlighted many contradictions of our modern lives in a world which is hyper-global and also hyper-local. We have the opportunity to know what's happening in the globe instantly in a way that we didn't, for example, in the 1918 pandemic. And yet sometimes our local view is so myopic that we can't see outside of it. Why have our godchildren in England, my family's, been in school all year? And yet when the American Academy of Pediatrics said last summer that reopening schools should be a priority, that response was met with skepticism and sometimes even strong attacks and became quickly highly politicized. And yet, perhaps as spring arrives, there is a thawing and renewed hope. Many of the policies and decisions in place to bring some number of California children back into schools in person within the next week seem to be coming to fruition. Today, we have 3 leaders in the conversation about reopening schools who will help ground us in science, will help us understand the evidence that informs school reopening policies and decisions from the public health side. They'll bring us up to date on where we are as a state in terms of school reopenings and what types of mitigation strategies will need to be in place to reopen schools safely and successfully. We'll also hear about equity issues as we face a state in our youth population during this pandemic and how that plays out in our school reopening process. The equity issues we face as a state, Our session will proceed as follows. We'll start with Dr. Jean Noble, Dr. Raul Gutierrez, and then our final presentation will be by Dr. Naomi Bardock, who will join us promptly. And following all of our presenters, as usual, we'll have a Q&A session. So please do submit any questions you have on the by using the Q&A question box in the control panel, which is located on the right-hand side of your screen. Now, I'd like to turn the time over to Dr. Jean Noble. Dr. Noble is an associate professor of emergency medicine at UCSF. She's the director of COVID response for the UCSF emergency department. She's led a large emergency department through times of inadequate PPE and limited access to testing, with 0 cases of patient to provider or provider to provider COVID transmissions. She's also advised not only several Bay Area hospitals, but also Bay Area schools, sharing data on safe reopening strategies. Jean has been a tireless advocate for following evidence-based approaches to reopen, paying close attention to the mental health consequences of COVID-19 on our youth. Thanks, Jean, for joining us today.
Thank you so much for having me. All right, so school closures and the mental health crisis among our youth is what I will be talking about. We are at 1 year and counting. Next slide, please. So why did we close our schools? Back in March of 2020, we thought kids would be the primary drivers of COVID. We thought kids would be at risk of severe illness. We thought schools would be super spreaders. We thought school closures would save tens of thousands of lives. And now we know that we were wrong. Next slide, please. What we have known for many months is that adults are the primary drivers of COVID. Kids are extremely unlikely to have severe COVID disease. In fact, there's only been 16 deaths among people under the age of 18 from COVID in the state of California since the beginning of this pandemic. That compares with 16 deaths for a single flu season, average flu season, among people under the age of 18 in the state of California. In contrast, about 200 adolescents, 225 in 2017, died from suicide. And adolescents disaggregated by 13 to 18-year-olds are about 14 times more likely to die from suicide than they are from COVID. You'll see in the lower right-hand corner the case fatality rate by age. We see that for 0 to 19-year-olds, COVID has a 0.003 case fatality rate compared to over 5% for persons over the age of 70. Next slide, please. So school safety, we now have a real preponderance of evidence about safety. So what do we know and when did we know it? In the fall of 2020, just when our schools were about to open in many places, we had a lot of observations of minimal school transmission from many countries in Europe and in Asia. And then when we got a little further into the fall and some schools did open, we had similar observational data from New York and Florida and even from open schools in California. In December of 2020, the CDC published a study from Mississippi showing that kids who attended in-person school were less likely to acquire COVID than kids who were out of school. And in January of this year, we had several high-quality studies be published in North Carolina, in Wisconsin, in Georgia, and elsewhere, showing that schools K through 12 could reopen safely, even in the face of really high levels of community prevalence. Next slide, please. So what's the ultimate measure of success when you open a school safely? It's the number of school-based transmissions. So here in Marin County in the Bay Area, there's a great data analytics team that has been displaying their school-based transmissions from the beginning. So they have had thousands of kids back in school since September. They now have, or will have in 2 weeks, all of their schools open for in-person schooling. They have tracked the number of student days on campus, meaning students and teachers showing up to school for in-person learning, multiplied by the number of days schools have been open. So they now have accumulated 1.6 million student or person days on campus. And during those 1.6 million days of exposure, they've had exactly 11 school-based transmissions and 0 student to teacher transmissions, 2 teacher to student transmissions. So overwhelming data of safety. And it's not simply that Marin is a resource-rich county and this couldn't be reproduced elsewhere. There are districts in Marin, including Marin City, that primarily serve kids of lower socioeconomic status, and they have done equally as well. Next slide, please. So looking a little more closely at some of these studies that I referred to, so exposures predicting COVID infection in populations under the age of 18. So the Mississippi data that was published by the CDC looked at kids between the months of September and November. It was a case control study, so they looked at children who tested positive and then case control matched them for kids of similar socioeconomic status for kids who tested negative for COVID, and then went back and looked at their exposures over the previous 14 days. So exposures that predicted a positive COVID test were play dates, having attended a social gathering, or having visitors in the home. The only statistically significant factor that predicted a negative COVID test was having attended in-person school or childcare during the previous 14 days in a setting where masking was enforced. So the conclusion of the study was that social gatherings, not schools, are higher risk for COVID transmission. Next slide. And then in January, we had really a watershed study published by researchers from Duke University, published in the journal Pediatrics. They had followed 90,000 K through 12 students and 10,000 teachers across public schools in North Carolina during times of incredibly high COVID prevalence in the community, up to 29 daily cases per 100,000. And they found 32 school-based transmissions during the 9 weeks of their study. When community prevalence would have predicted around 900 transmissions, there were just 32. And again, there were 0 student to teacher transmissions. And middle and high school students had lower rates or equivalent rates to K through 6. So older kids were not higher risk, even though they were moving from classroom to classroom. The strategy, the public health strategy that kept these teachers and students safe, they defined as the 3 Ws, which were wear a mask, watch your distance, wash your hands. But the primary investigators of the study really say the big intervention was universal masking. They achieved masking of over 90% of all persons on campus, and that's really where they put their effort, and it paid off. Next slide. Then we have data from Wisconsin, again, K through 12 schools, public and private, rural schools predominantly, while the North Carolina study was a mix of urban and rural. These schools were, 5,000 teachers and students were followed during really high times of community prevalence again. In fact, when test positivity rates in the community were up to 40%, which is almost unheard of. And during their 3-month study period, there were only 7 cases of school-based transmission, 2 among middle schoolers and high schoolers, and 5 among K through 6. This again was due to universal masking. There was variable enforcement of physical distancing, and half of the students got to school on public buses where distancing was not enforced. 0 student to teacher transmissions, and overall it was and school classroom sizes were limited at 20. But again, this was a case of really good protection based on universal masking. Next slide. And this graph just shows that community prevalence rates did not correlate with school transmission. So the black line graph you can see goes way up during November of their study. And school transmission is there along the bottom x-axis, just bouncing around 0, not correlating to community rates at all. Next slide. And back in December, just before all of these studies came out in January, an expert council made up of researchers from Harvard, Brown, Tufts, and Boston University had already concluded that there was a lot of evidence that schools could be operated safely. And they declared, we can now recommend that schools be open, even at the very high levels of spread we are now seeing, this is during the winter surge, provided that they strictly implement strategies of infection control. They went on to recommend 3-foot distancing for young learners at all levels of community spread, and 3-foot distancing for high schoolers below a daily case rate of 100 per 100,000. roughly 4 times above the limit that we use for school reopening in California. Next slide. So all of this data really underscores that kids can attend school safely, that there's very little transmission in schools, and kids from the get-go are not particularly at risk for severe COVID disease. But of course, teachers are, and we don't want kids to bring COVID back to their parents. But kids are not, COVID is really not a pediatric disease, and the data shows that schools can be operated very safely. So what then are the harms of school closure to our children? What kills kids? It's not COVID in particular. So we have highlighted here 5 to 14-year-olds have about a 1 in a million chance of dying of COVID. And they have about a 10 in a million chance of dying by suicide. So 10 times higher rate of suicide than COVID. And for 15 to 24-year-olds, they have about 10 in a million chance of dying of COVID and 100 in a million of dying of suicide. So it's just goes to show you that suicide and mental health has always been a significant risk for young people. And you see there in the middle that traffic accidents are also a big killer, but it puts COVID sort of in perspective there. Next slide. So back in November, the CDC was already publishing data of harm. So we had sharp increases in ED visits for mental health reasons in 2020 versus 2019 for kids between the ages of 5 and 11. The increase was 24% in ER visits for mental health reasons. And for kids 12 to 17, there was almost a 1/3 increase or a 31% increase in the number of kids seeking emergency mental health services. Next slide. And then this was a white paper that was looking at insurance claims by type of healthcare visit. So in the green, we see the percent increase of mental health visits for kids ages 13 to 18 in 2020 compared to 2019. So for every month of the year that was looked at after school closures, there was a large increase ranging from 20% to over 100% or doubling of kids accessing mental health services. And then in the purple, the decrease there, the lower half of the graph, that just shows that healthcare visits overall for kids were down in 2020 compared to 2019, which mirrors what we see in adults. People have accessed healthcare services less during the pandemic. But if they do access services and they're a child, they're more likely to be accessing mental health services. Next slide. And then here are a couple of national surveys. On the right there, we see that essentially 3 out of 4 parents describe their children's emotional health as having deteriorated during the pandemic. And on the left, we see that about 1 out of 5 teen boys has had a new or worsening problem with depression or anxiety during the pandemic, and about 1 out of 3 teen girls has had worsening or new depression or anxiety during the pandemic in time of school closure. Next slide. And then we have our own local data. This is from Benioff Children's Hospital of Oakland. Here we see an increasing number of children requiring emergency mental health services. So the red line above is 2020 compared to the gray line below in 2019. And month for month, starting in April, we see an increasing number of kids coming in needing emergency health services than the year prior. Next slide. Also from the Children's Hospital of Oakland, we saw a 75% increase in children requiring immediate hospitalization for mental health needs. So in 2019, 32% of kids coming in for emergency mental health services needed immediate hospitalization. That rose to 56% in 2020. Next slide. We also saw more than a doubling in the number of adolescents requiring hospitalization for eating disorders at the Children's Hospital of Oakland. So the average daily census of adolescents hospitalized for eating disorders was 3 in 2019, and that rose to just over 7 in 2020. Next slide. And then finally, in our Ask Suicide question screen, so we asked all 10 to 17-year-olds who come into the ER if they are having active or recent thoughts of suicide. And the gray line on top is the combination of current or recent thoughts of suicide. So between March and October, we saw a 66% increase in the number of kids screening positive for active or recent suicidal ideation in the Children's ER of Oakland, and that trend has continued through January of this year. Next slide. And in UCSF's Children's Emergency Department in San Francisco, in January, we saw the highest proportion of adolescents on record screening positive for active or recent thoughts of suicide. Next slide. So mental health and COVID, did school closures cause the mental health crisis? That's a question I think that is often brought up. And I don't know that it's the right question. Regardless of the cause, the solution is the same. Although many kids and many parents identify school closures as the source of their despair, in a sense, it doesn't really matter because we know what is best for kids who have worsening depression, anxiety, or social phobias. They need to normalize their routines. They need to see other people. They need to exercise. They need to expand their social networks, link to resources, get out of the house. All of these things are provided by in-person schooling. Next slide. And so how does California compare? So California is one of only 5 states in the country that chose to hold back school reopening based on community prevalence. And nationally, California remains dead last for the proportion of kids who are back in person in school, K through 12th grade. And globally, California ranks near Panama, El Salvador, Bolivia, and Bangladesh in having the fewest proportion of kids back in school and the longest closures. Less than a third of California kids currently have access to in-person education. Private schools are largely open. Suburban public districts are now opening slowly, but urban districts that serve most of our kids of lower socioeconomic status and where communities of color are more likely to live are remaining closed. Teachers unions have done a lot of focusing on hesitant families that are worried about sending their kids back to school. And what we really need but have not yet seen is a state campaign of trusted messengers. Yes, we can open schools. Just like vaccine hesitancy, it's understandable that communities, especially those ones that have been particularly devastated by COVID or have been hit harder by COVID than others, are more hesitant about sending their kids back to school. But we know the data. We know we can do this safely. We need to get out there messaging that schools can and should open now. They can operate safely. Keeping kids at home is harming their health. We really do need that from the state. And I'll just end by saying, school really is the essential business of childhood. Our kids are in crisis. They have been out of school far too long. We know we can operate schools in person safely, and the time to do so is now. Thank you.
Thank you, Jean, so much for this and for all the work you've been doing this. Now we're going to turn to Dr. Raul Gutierrez. Dr. Gutierrez is a community pediatrician practicing at Zuckerberg San Francisco General Hospital. He's also an associate clinical professor with UCSF and co-directs the Center of Excellence for Immigrant Child Health and Wellbeing. He's currently the co-chair of the American Academy of Pediatrics Council on Immigrant, Child, and Family Health. Dr. Gutierrez has helped us keep equity at the center of the conversation about how to reopen schools safely and successfully, and for that we are grateful. So take it away, Dr. Gutierrez.
Oh, thank you so much, and thank you for having me. So we're just going to talk a little bit about thinking about equity and how equity kind of comes into the conversations that we're having about school opening as well as vaccinations. Next slide. And first, I want to acknowledge that several of us here on this webinar, whether it be interfacing with our school districts or community partners, whether we're parents, or providing care directly within schools, that this is definitely challenging. And so I want us to acknowledge that we are in the midst of unprecedented times. We acknowledge that we are holding a multitude of feelings, responsibilities, fear, and joys at the same time. We acknowledge that there are many responses to stress and uncertainty, each of them valid. We acknowledge that there's no better opportunity to practice compassion and collective care than right now. This is the work. And we acknowledge the critical need for reflection, inquiry, and prioritization of the most critical needs. Next slide. So in California and across the United States, COVID-19 has disproportionately impacted marginalized communities, and essential workers from these communities have experienced more disease, more death, and the most severe economic impacts. Here we see the rate of cases and deaths in the United States as a whole through March 7, 2021. And we see that there is a disproportionate impact on communities such as the Native Hawaiian Pacific Islander communities, American Indian Alaskan Natives, Latinx communities, and Black communities. Next slide. And in California, the pattern is similar. And here in particular, we see a quite disproportionate impact in cases with our Native Hawaiian and Pacific Islanders, as well as our Latinx populations. And then we see that reflected in death as well, particularly for the Black community. Next slide. And as Dr. Noble mentioned, the death rate in kids has been very small, 16 in total. But looking at the cases, we see that the Latinx children ages 0 to 17 in California are way disproportionately affected by COVID infection, representing 65% of cases, where they only represent about 48% of the population in California. Next slide. And I also want to break this down by some other kind of parameters. UCSF partnered with community-based organizations in this United in Health initiative to do various types of test and response in the Mission District of San Francisco, with a majority Latinx population in that area. And in their analysis, they found that Latinx were overrepresented in positive cases. Risk factors for recent infection were attributable to inability to shelter in place and maintain income, frontline service work, particularly those who were day laborers, unemployment, household income less than $50,000 a year, high density households in Spanish preferred language. Next slide. And so why are we seeing this inequities? Why are we seeing this association with marginalized communities and those that are disenfranchised from several different parameters? And one of the things that I think is helpful to think about in thinking about this question is this concept of structural racism, or the totality of ways in which societies foster discrimination through mutually reinforcing inequitable systems that in turn reinforce discriminatory beliefs, values, and distribution of resources, particularly around the distribution of resources. Next slide. And to understand this a little bit, we can look at it as kind of social determinants of framework, but add to that what some folks and thinkers and analysts are saying is looking at the root cause or structural discrimination, which includes racism, that is informing the tools such as political processes, statutes, budgetary decisions, regulations, and enforcements on the different systems in which we walk around, whether that be public health, our neighborhood and built environments, education, and economic stability that downstream really affect health and well-being. All of this has implications for health downstream, whether that be COVID, morbidity, and mortality, or mental health outcomes in the setting of school closures, as we just heard from Dr. Noble. And the one thing that I really want to point out here is that science and the data that we have out there is also another tool that very much informs policy. And it's really important for us to critically understand and analyze how we are using that data, who is providing that data, and who has access to that data to make policy decisions that then affect all these different systems that we walk around in that eventually lead to health and well-being outcomes. Next slide. And so I do want to acknowledge, and as we all know, disparities do exist in education as well. I'll be using San Francisco Unified School District here and some of their student achievement reports here. And we can see that looking at mathematics, achievements in mathematics and English language divided by a subgroup, ethnicity and race, that there's a huge discrepancy in achievement, a huge gap, particularly for African-American communities, Latinx communities, Pacific Islanders, and English language learners. Next slide. And then on top of that, during the pandemic and during school closure, we continue to see a widening of those disparities. Here we're seeing disparities in learning loss. So this is looking at English language and mathematics assessments based on socioeconomic disadvantage by grade level. And we see that looking at 0 in the middle to the left is learning loss, and to the right is learning gain. And we can see consistently there is disparity in learning loss, with more loss and less gain seen in those who are socioeconomically disadvantaged. Next slide. Additionally, we see disparities in access to in-person learning in California. Here we see access to in-person, hybrid versus distance learning only, broken down by race and ethnicity. And again, we see that about almost, 32% of white students have in-person or some hybrid model access, whereas the majority of our Black and Latinx communities are distance learning only. Next slide, please. And we're seeing the same story play out in vaccinations. So this is race ethnicity of those vaccinated to date in California. And we're seeing a huge gap in the Latinx community in particular in terms of access and receiving a vaccination. So here we see that 20% of doses have gone to Latinx communities, whereas they make up 40% of the population. And that gap we see throughout the country, and the gap differs depending on where you are, and that difference can be seen in different counties in California as well. There is potentially some narrowing of that gap as we start to open up access to vaccinations and those who are eligible to get vaccines. We will see if that gap narrows even more next month when vaccines are opened up to everybody in California. Next slide. So some of the barriers to vaccine distribution in historically marginalized communities include lower access to primary care, challenges using internet-based appointment systems, lack of transportation to vaccine sites, information not available in appropriate languages, concerns about cost or insurance coverage, with some communities not even knowing that this is free to them, and particularly for undocumented communities who don't know that this is available to them as well as distress under lack of accurate information in the community. And this can sometimes compound upon each other to create particular communities who are more marginalized than others in terms of access to vaccines. Next slide. So what does this mean for our public schools? So this is enrollment data from California in terms of our public schools. And looking at our students, we see that about 60% of children are socioeconomically disadvantaged. And almost 55% of students are Latinx. And that goes up to about 60% for communities of color, if we put it all together. So when we're talking about vaccine access and when we're talking about opening schools, we really need to be talking about conversations with our communities of color. Communities that have been marginalized historically and that continue to be marginalized now, and who have a different experience with this pandemic than, say, their white counterparts or in other areas of the country. Next slide. So I think it's important to really embrace health equity when we're having these conversations, and to use that framework and use that lens when moving this conversation forward. And so health equity is the principle underlying a commitment to reduce and ultimately eliminate disparities in health and in its determinants, including social determinants. Pursuing health equity means striving for the highest possible standard of health for all people and giving special attention to the needs of those at greatest risk of poor health based on social conditions. Next slide. So some of the ways in which we might be able to do this. So one, we know that data demonstrates that it's possible to reopen schools safely without the vaccine. However, vaccines for teachers is an important policy tool that will facilitate resumption of in-person education, which is important to mitigate education and health disparities of children in general. Mechanisms must be in place to reach teachers, education support staff, and parents of students, particularly in BIPOC communities, and resources must be in place to support as many proven safety measures as possible. Vaccinating students' family members with risk factors for infection will hopefully make families and education stakeholders more comfortable sending children to school, and we must be prepared for vaccination of children when that time comes. Next slide. Some of the things to consider is to have community-specific, multi-sector, equity-oriented initiatives, adopt mechanisms that identify structural discrimination, acknowledge it, and work to undo it, institute policies to increase economic empowerment in communities, fund community programs that enhance neighborhood stability as we start opening schools, focus on addressing both the social risk factors as well as the unmet social needs, particularly when we start opening up schools and may find some infection in children, depending on where we're at and how that is handled, and test and deploy targeted interventions that address social risk factors as well. Next slide. Some things that I wanted to highlight in terms of, I thought, examples that we could mimic or try to, not mimic, but try to institute that feel like best practices and kind of take equity into account. So prioritizing distribution of vaccines and resources to zip codes severely affected and that have high indexes of economic hardship. The example here is partnering with the Latino task force and the mission of San Francisco for testing and vaccination, partnering with community organizations and other trusted sources to create targeted messaging to promote vaccine awareness and uptake. And for this one, I particularly wanted to highlight the Pediatric Advisory Task Force from UCSF over at Benioff Children's Hospital in Oakland have been offering information sessions with Oakland Unified School District, and has really helped to inform communities in moving their initiative forward to open schools. Next slide. Prioritize vaccine distribution to those who face access barriers. So vaccination sites that are near public transportation or hours of operation that are accessible to those who work. Simplify registration procedures, considering the digital and language access divide. So offering non-digital options or minimizing pre-registration. For example, at Zuckerberg San Francisco General, the vaccine clinic opens daily 9 to 3 without any appointment required. Next slide. And so some of the key points that I wanted to leave with, I would hope you all leave with here today before getting to Dr. Bardock's presentation, is one, structural racism involves interconnected institutions mutually reinforcing inequitable systems that in turn reinforce discriminatory beliefs, values, and distribution of resources, which together affect the risk of adverse health outcomes resulting in BIPOC communities bearing a disproportionate burden from COVID-19. The pandemic has amplified the structural and economic factors that contribute to inequities in education and other social drivers of health. Long-standing systemic racism and historic scientific misconduct contributes to BIPOC individuals' reluctance to trust the medical establishment. That is a truth. We need to acknowledge that. BIPOC communities' experience with the current pandemic is different, with increased exposure, risk, and impact. We must acknowledge this and understand how it frames discussions for vaccines and returning to school. Science and data is a tool that informs policy. We must be critical about how that information is delivered, who is delivering it, and who has access to it so that it is used with equity in mind. And next slide. I think that's all I have for everyone today. I will hand it off.
Thank you so much, Dr. Gutierrez. Such important work and a really vital perspective as we think about this issue in our state. Our final presenter today is Dr. Naomi Bardock. Naomi is an associate professor of pediatrics and policy in the Department of Pediatrics and the Philip R. Lee Institute of Health Policy Studies at the University of California, San Francisco. After months of putting on her researcher hat and reviewing all of the worldwide data around children and schools and COVID-19 spread, and of translating that data into digestible information for physicians and policy leaders and the education community, Naomi was tapped by the state to bring her expertise and wise thinking to our state school reopening policy team. I can only begin to imagine the complexity of the stakeholder conversation she's had to navigate in this very fraught issue. And we're all so lucky to have her in that role, as well as here today to share her important work and an outlook on the schools in California. It looks like we're having a moment of technical issues with Naomi's video, but I think I can hear her, so.
Yes. Okay, wait, sorry, let's see if that's gonna work better. I don't know why this is having issues. Sorry guys, hold on 1 second. 1 second, see if this is gonna work for us. Maybe not. All right, well, I have this funny downward, this funny angle looking at me from below, but I think I can still give a talk, even if I look funky on camera, I can handle that. So thank you so much, and why don't we go to the next slide? Excellent, and I'm talking today sort of as and I apologize, I wasn't able to be here for Dr. Noble's initial talk, but I was able to see some of her slides ahead of time, so I sort of know the framing there. And then also for Dr. Gutierrez, I was able to see most of his talk, so I am giving this presentation in part in sort of in the context of those two talks of like, how do we think about how are we going to move forward? How can we try and get as many kids back into school as possible in California in a way that is equitable, in a way that is safe. So safe in-person instruction. And I'm currently the lead of the Safe Schools for All team in Governor Newsom's administration, but particularly within the Health and Human Services Agency. So working with Dr. Mark Galley, and the Safe Schools for All initiative was a plan that was announced by Governor Newsom in December, late December of 2020, deep in the deepest and darkest days of the pandemic. But it established the Safe Schools for All team with the hope that as we were coming out of those darkest days, that we would actually be able to have people stay focused on the idea of, even during a very difficult period of the pandemic, that we would be able to try and aim for getting more schools reopened as we came out of that. The framework is built on several pillars. One is funding to support safe school reopening. Another is school safety and mitigation measures. Another is an equity focus. And I'm sorry, it looks like the slides got a little bit cut off, but there's also accountability and transparency as another piece of it, and then technical assistance. So we know we can't just give people money. Giving money to schools and expecting them to be able to do this very complicated thing of reopening them is not enough. So we make sure that we're also offering a lot of technical assistance. Next slide, please. So it's always helpful for people to remember the pathway forward is this. What is this? It's a wide open road, but there's two very important guardrails that we're always being mindful of. And in the darkest days of the pandemic, and still today, I'm always trying to think about both of them. But on one side, if we open too quickly, it's going to drive potentially increased rates of infections, increased risk to the community. If people, we've seen it, lots of outbreaks can happen if people don't have masks on, they're not doing any of the sanitation layers. That's not, we need to make sure we're not doing that. We owe it to our families, our teachers, our students. On the other side is kids not getting a whiff of in-person learning for over a year, which that has happened. That in many, as Dr. Noble described, many in California are in that situation. Also totally unacceptable. We have to do better than that. Next slide. And the pathway forward, if you can go to the next slide, is instead of crashing into one of those guardrails, the way we know the way forward is to do those safety mitigation layers. If we have those layers in place, you can do safe in-person instruction. And that's the goal of the Safe Schools team. Next slide. So, you know, we know more now than we did in March, and Dr. Noble sort of went over much of the data that we already have. Next slide. And I like to just give the brief summary of what is it that we know. You guys have already heard most of it. Children get COVID-19 less often and are less ill than adults. They do not seem to be major sources of transmission to each other or to adults. Transmission in elementary schools differs from high schools, particularly in the absence of masking. Adult-to-adult transmission is the most likely and also therefore where we have the most control. And community prevalence is going to affect school-based cases, which I think Dr. Noble presented in her data on the North Carolina schools, but not necessarily in school transmission if we have those key mitigation strategies in place. That includes the masking, physical distancing, stable groups, ventilation, hand hygiene, symptom screening, screening for contacts, and surveillance and testing. Next slide. So what do we know more than we did March? This is the summary: masking, 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 physical distancing, stay home, ventilation, symptomatic, asymptomatic testing, and small stable groups. And next slide. The one thing I really want to emphasize in case you guys haven't heard this or messaged, if you're getting questions from folks in your clinical roles, disinfection is no longer something that is an emphasis in the school's protocols. So it used to be clean frequently, disinfect frequently, many times a day, deep cleaning, disinfection in order to be able to decrease that risk of infection. And we know since March, we figured out that's actually not a major source of transmission. And it's a huge barrier for schools if they feel like they have to do a lot of deep cleaning. So to the extent you guys message to folks about that disinfection, you can help decrease that myth and decrease the sense of burden that people have to do with that. Next slide. So the approach at the state level is we try very much to do an evidence-based approach. I personally follow the data very closely, as Dr. Noble, Dr. Gutierrez, and Dr. Knoll can all probably attest to. We generate new data if possible. I did that more when I was at UCSF and less now that I'm at the state job, but we're still generating some new data and looking at data in California. And then the implementation is based on the data, recognizing the need for stability and forecasting for school function and school community well-being. So trying not to do things that are that move too quickly in a way that is going to actually freeze people up. When people are on a process of getting things opened, sometimes if there's a lot of stuff that's coming at them quickly, then sometimes they have a harder time responding. So we're always being mindful of who are all the stakeholders, how can we help to make sure that things are moving smoothly and continuing to move in the right direction. And then I'm going to go through basically some initiatives and recent guidance changes for people to sort of understand how are we doing? What do you do on the policy side to try and help make things happen? And we'll talk about vaccinations, physical distancing, 86, which is a bill that got passed. I'll describe a little bit more about. Excuse me, high school and middle school reopening criteria, testing resources, including, we can talk a little bit about symptom screening, although I didn't end up making slides about it, and then also the use of PPE and masks and having access to those things. Next slide, please. So we know that this is probably very familiar. Most of you guys, multiple layers improve success. There are individual, personal responsibilities. There are shared responsibilities. Vaccine is called out at the end. This is a really nice slide from the New York Times, courtesy of Dr. McKay and a virology group. And so it is one of the key interventions that we have done over the past month or so at the state level that really is helping to drive school reopenings. And Dr. Gutierrez mentioned correctly that we already knew how to do safe schools even without vaccines in place. We knew those safety layers were important and how to do them, but the vaccines really have given people a lot more confidence. Next slide, please. So this is just a brief overview of the of what we did, what the sort of state initiative was, focusing really on education worker vaccine distribution. There were 3 different buckets where people were getting their vaccines, and almost every educator as well as childcare worker throughout the state have been offered and has been offered a vaccine. Almost all of them have taken it, not necessarily everybody, because there's definitely some pockets that are fewer people have taken it than others. But it's basically through these 3 different buckets. Counties were already doing a bunch of initiatives. This is the big state level one, which is that people got dedicated access using very specific codes from the county offices of education, distributed throughout all the schools for anybody who is already doing in-person instruction or was slated to go back within the next couple of weeks. And that's an important piece of the equity question. Again, we know that many of the schools in the fall that were open were higher SES communities and private schools. And so we wanted to make sure that these codes that were going out were also for people who were committed to going back and were about to have a higher level of exposure, even if the schools hadn't already been open. And then the FEMA partnerships, which I think many of you guys know, these are the big mega vaccination sites. So education workers were already prioritized for that. So the allocation for this My Turn access was also based on equity. So giving more codes to communities who have a number of education workers, and then also the extent to which those workers were serving children who had been disproportionately impacted by the pandemic. And of course, the qualification is based on exposure, how much exposure you're actually having. Next slide. So that was the vaccine initiative, and as I mentioned, is very successful both in terms of getting vaccinations to people who wanted them, and then also helping to encourage schools to open. So LAUSD, Oakland Unified School District, Sacramento City, a lot of school districts opened that were not planning on opening because of that vaccination push. It gave people a lot of confidence and movement, which was great. The other piece is to talk about the physical distancing. I'm not going to go into too much detail here just because we don't have tons of time, but there was a recent change in our guidance reflecting several different pieces of data that changed the guidance from being a 6 feet of physical distancing recommendation with a floor of at the minimum and no lower 4 feet of physical distancing. The new California guidance says that it can do it's a strong recommendation for a minimum of 3 feet. And the context for that is, first of all, a CDC MMWR paper on the ill effects on children and families. That is really the first paper, which I'll describe in a minute, that sort of helped to parse out those mental health effects that Dr. Noble was talking about and other physical effects based on type of instruction that kids were having. So that came out, I think, the Thursday before CDC changed their guidance on a Friday, and CDC changed their guidance on a Friday, also going from 6 feet to 3 feet. And we changed our guidance the next day on Saturday because we had been following all the data very closely, which had already been coming out the week before that. And the data supporting that was 3 feet, and particularly I always want to say out loud, it's 3 feet in the setting of masking. So it's not like, oh, everybody should just go back to school, pack them in, and don't worry about anything else. The data really shows that if there's masks that are in place, it's extremely reassuring that we can have a closer physical distance. More kids can be in in-person instruction, and therefore it's the right thing to do. If we don't have to do 6 feet, then we shouldn't do 6 feet. So that data comes from Massachusetts, Utah, Wisconsin, Chicago, and then we have some California data that we were gathering that is, as of now, still unpublished. Next slide, please. So this is the first study I was talking about on that slide. It's a survey, and basically they reported on student outcomes as well as on parent outcomes. And for those in hybrid or virtual learning, there are worse student outcomes in physical activity, time spent outside, in-person time with friends, and then worsened mental or emotional health. Next slide. And for the parent outcomes, also worse for those in hybrid or virtual learning compared to those in in-person learning. Students in in-person learning, worse, increased loss of work, loss of job stability, greater emotional distress, and difficulty sleeping. Next slide. So this, so in the context of that study, which is like, you know, here we go again, we know that schools being closed is not going to be good for folks. So then we think about all this other data and, you know, the strength of this data. It's not perfect. There's no randomized control trial, but there's pretty decent data. This is from Utah. There's a low secondary attack rate in schools with 3 feet of distancing between students. They looked at 20 elementary schools. They actually, it was a very good contact tracing study. So they looked at 51 index patients, over 1,000 contacts, a very low secondary attack rate, and the median distance between seats of 3 feet. Next slide. In Massachusetts, they looked at schools with a policy of 3 feet and a policy of 6 feet, 251 school districts, 537,000 students, and almost 100,000 staff. And they looked at 16 weeks of school from September to January. Masking was required in all schools, and the incident rate ratio was basically very similar between 3 feet versus 6 feet. Both of those incident rate ratios for the students, 0.89, and for the staff, 1.1, cross over 1. Meaning that there's no difference, no detectable difference between 3 feet and 6 feet of physical distancing in schools based on their case rates. Next slide. The community case rates outside of the schools, they did vary over time and actually got very high at some, you know, as the whole country went through a big surge. So they were adjusting for community case rates in case there was a difference between those who had a 3 feet versus a 6 feet policy. The limitation is that it's case rates only, and they only looked at written policies rather than actually physically observing people in schools. So some people have objected to the study because you're not actually observing people in schools, but you have to think about it. Well, how could we have gotten that wrong? How, you know, what would make that study no longer applicable? You would have to have had 3 feet schools placing students at 6 feet in order to change the implications of the article, because, you know, and the likelihood of somebody saying I'm going to do 3 feet and then putting their kids at 6 feet is extraordinarily low. So I think it's just helpful as people are criticizing that article. I think it's helpful to think through that limitation and why it's actually probably a very unlikely limitation to affect the implications. Next slide. I believe that Dr. Noble already went over this one. Basically, it's you know, talking about Wisconsin and very little in-school transmission. And the only thing to say out loud is that they had a staff maintaining 6 feet of distance, but the children, the students actually, K through 12, many of them were at around 3 feet. Next slide, please. And then lastly, the Chicago parochial schools also had very limited physical distancing in their cohorts. They did between cohorts, so 2 groups had to stay apart, but within a cohort, they didn't actually say there had to be physical distancing, and they had a very low attack rate of 0.2%. And they did a whole bunch of also safety mitigation layers, so that masking again comes up as important. Next slide, please. So taken together, this was for us and also for the CDC, a compelling case to change to a 3 feet of physical distancing policy, supporting those twin goals, keeping us in between those guardrails, thinking about safe but also successful schools. Next slide. So the other piece is the Assembly and Senate bill that got passed just a few weeks ago. It allocates $6.6 billion from the state of California to schools. There's other federal monies also coming into schools. But these were specifically California dollars that the legislature had to approve. And $2 billion in particular from that went to schools, is slated to go to schools operating on April 1st or after for in-person instruction. So the idea there is to really support people. If they're going to do in-person instruction, they should be getting those dollars, and they should be getting those dollars soon. And it also creates some incentive for schools to sort of say, okay, I have a deadline, you know, give somebody something to aim for. And so that was sort of the hope of these dollars, that would help focus people a little bit. And then there was also an equity-based allocation of those dollars. So more dollars went to schools with higher proportions of disproportionately impacted students. And the dollars can support health and safety, learning loss mitigation, mental health, kind of everything. You can use those dollars for anything to support in-person instruction. Next slide. And then the other piece of guidance that changed is the high school and middle school reopening criteria. When we changed the physical distancing criteria on the requirement, we also changed the middle and high school reopening criteria. So now they can open in purple if the case rate is less than 25. That makes them parallel to the elementary schools. And it affects, there's a number of counties in California that are still in purple, so it allowed those high schools to reopen. This is a map from our transparency effort, which is schools.covid19.ca.gov has that's our schools hub, and it gives a ton of information about schools in California, but this includes also just the information about what kind of instruction is going on, in-person, hybrid, or distance learning. And then, and this is our high school map, which you can see is a lot of pale school districts and counties. So our hope is that this is going to change over the next several weeks as those monies start to flow, and now that there's a change in our criteria. Next slide. So I like to have people think ahead a little bit, and this is what we're trying to do as policymakers. And there's the present moment, and then there's like, let's think ahead. So there's a light at the end of the tunnel. We know it's coming. It's with vaccines. It's like totally a blessing, but we are still in the tunnel. We have to think a little bit about surge that might come up, and there's a surge that I know nationally we're worried about. I'm a little bit worried about it in California because of variants which are more contagious. We also know spring break drives travel, and other holidays have driven community-based increases, which then sometimes leads to schools losing confidence and worrying about closing down. And I got called the other day by a reporter saying, aren't schools going to be a super spreader event after spring break? And so we do need to be thinking about that right now. And so one of the things that we're trying to emphasize, California has a massive testing capacity specifically for schools, for school-based testing programs. And so I'm going to tell you guys a little bit about that. And I think it's something that I've been encouraging schools, local health jurisdictions to be thinking about accessing, especially if the vaccination rates are not high in their community. Next slide, please. So there's the California DPH Testing Task Force for Schools. It's easy to find online if you just Google that, or you can do TTF CDPH schools. And they offer both a pretty robust PCR testing program, also antigen testing. What they do is it's not the deep nasopharyngeal one that no child would ever agree to again after having done it once, and many adults refuse to do it again. It's an anterior nares collection, both for PCR and for antigen, and they can do student supervised self-collection, meaning that you don't have to lean over the school personnel, don't have to lean over the students and put that deep nasopharyngeal swab into the student's nose, which many people are very anxious about. Next slide. So just briefly, I'll tell you guys about the PCR program and the antigen program at the state. The PCR program, the most important thing that people talk about, not the most important, one major thing is that they talk about, not just the types of tests. So you guys as clinicians, many of us think about, PCR versus the antigen, which one should we do, which is sensitive and specific, and what's the right one for us in clinical diagnostic situations. I think there's a couple of things to think about for schools if you're giving any guidance to your schools, you're helping them think about it. One is the funding. So PCR tends to be much more expensive. The Valencia branch lab, which is the state lab, has made it much less expensive. It's $21 per test, but they also upfront all of the costs. They'll pay for everything first and send schools kits, and then they will actually gather insurance reimbursement information, and they will do the insurance reimbursement. And they negotiated, the testing task force folks negotiated with Medicaid so that all student asymptomatic testing for Medicaid children or students covered by Medicaid is covered, actually. So the asymptomatic testing students didn't used to be covered, but now it is covered by Medicaid as of about, I think, early March. So that's a huge, huge win. The same thing is true for antigen in terms of the same system of funding it gets done. As you guys mostly know, antigen is a point of care test. It tends to be less sensitive than PCR, tends to have pretty good specificity as long as you're well trained. The strength of it is that it gives immediate results since the test is done on site. And why is that a strength for its schools in particular? The level of confidence in our pilot experience of doing antigen testing is that it makes a huge difference for teachers. And there was even a teachers union who actually felt like they could move forward much more easily because of the antigen testing option. Next slide. This is a brief slide about viral dynamics. I'll skip over it. This is the Michael Mina thing about you want to catch the transmissible virus. So don't do a test that's too sensitive, because then you're going to just be in a yellow shaded spot, which is not really infectious anymore. And so that's the argument for doing frequent antigen testing, which is part of what the state is able to offer at this point. Next slide. And this is data from some of our pilot testing. So the 0.2% testing positivity is in the antigen pilot, and 0.4% positivity in school testing statewide. That's very similar to numbers we're seeing in New York City, that's been doing asymptomatic testing for a much longer time than we have. But it's really helpful for people to know how low those rates are, particularly because as our community rates rise and fall, these low testing rates in schools actually tend to stay pretty low. That's the experience in New York. And it's important for people to know that, because it gives them confidence to walk through the door more easily. Next slide, please. And actually, sorry, not just walk through the door, but also keep the doors open, because otherwise in Massachusetts, early in when the fall surge started to happen, a lot of them shut down in Massachusetts, a lot of schools. But New York City schools stayed open because they were able to see with their asymptomatic testing that they had pretty low rates still. So just to summarize, the PCR availability through the Valencia branch lab is a big state resource. Like I said, easy to implement in school, low cost. The turnaround time is a little bit delayed, so people have to think about, the pros and cons for a school setting, whether they would like that or not. But a lot of schools actually throughout the state of California are using this PCR option through Valencia. And it's going to get even easier actually, because they're going to approve a possibility for teachers to be able to collect not just supervised self-collection, but actually they can go home and do it themselves and then just bring the test back. And so that decreases their workload as well. They don't have to go somewhere special to get tested. And the school doesn't have to provide personnel to do the specimen collection. And then the antigen program, which is now available through the testing task force, it just rolled out 2 weeks ago to be available. It was supported actually by a group called SOS, which is in partnership with the Public Health Institute. The antigen testing is really important to say out loud to any school who's considering doing that. It does require additional personnel and training, because you have to run the test at the schools. We do have a terrific partner called Primary, which is actually the partner that did the testing in the mission that Dr. Gutierrez mentioned before. Very experienced and really good at understanding workflow and supporting people to be able to actually get a lot of testing done in a short period of time. The Buy Next Now cards, which is what the state has access to, currently it's at no cost, and it eventually is going to be $5 probably per test. But again, that you can get that reimbursed through insurance for most situations, except for commercially covered insurance. Students are not covered for their asymptomatic testing. And then you can do the enrollment through the CDPH program, because California actually got a state level CLIA waiver for schools to be able to do antigen testing in schools without each school having to get a CLIA waiver. So there's a state level CLIA waiver held by Carol Glazer, who's a UCSF alum, who like basically holds on to that and oversees all the training and all of the results reporting and all that. Next slide. Self-swabbing, you guys can go see that video if you want later. It's an extremely cute video of a kiddo. I'll see if I can get you guys the link somewhere, but we won't have time for it now. Next slide. So I wanted to mention also equity in particular in the schools plan. As Dr. Gutierrez explained eloquently, that communities of color were disproportionately impacted, partly because of the essential worker, the structural racism associated with many of them being essential workers and living in high density living situations. What we're doing at the state level is we're actually doing a lot of technical assistance outreach to those communities of color. So it's pretty striking the difference between the conversations in some school board meetings where there's a lot of parents really, advocating for schools to be reopened, really, pushing very, very hard, and other school board meetings like in San Joaquin and other really heavily impacted communities where families come to those school board meetings and they say we don't really feel comfortable. Like we've had a lot of things happen in our families, and we don't really feel like school is a safe place. And so we're trying to do a lot of outreach to those kinds of schools to really support them to see how to make their schools safe and how to feel confident in going back and getting trusted messengers, like as Dr. Gutierrez explained. As you guys already heard, funding allocations and vaccine allocations, and then as I mentioned, communication with communities. Next slide, please. So to go back to the theme of this, the pathway forward, next slide. So we're in a new place since January, and I'm just going to forecast for one more minute, and then I'll hand off. Sorry for the Q&A. Next slide. So we have a key tool that we did not have in January. Next slide. These are our layers again. So planning for fall. What can we say about fall? And even late summer, we know that we're going to have vaccines. You know, the goal, pretty much April 15th, everybody's going to be eligible. So vaccines to all staff, adults living with staff, adults living with students, and students 16 plus. Next slide. And interleaved with that, we're going to have masks as mitigation because some staff may choose not to be vaccinated and younger students won't be vaccinated. Next slide. Oh, sorry. Can you go back to that other side? So you know, we know that we're going to have to, so the implications here is that between vaccines and masking, we can get rid of the physical distancing requirements, and also the stable group requirements is what we are anticipating, that this will allow us to be able to have a very, at least in terms of numbers of students on the ground, our hope is that we're going to be able to do that with pretty good confidence in the late summer and fall. Next slide. But importantly, how are we going to get there? We know that data are necessary but not sufficient, that school in-person instruction, the pathway is about hearts and minds as well as data. So we have to make sure we're informing teachers, staff, and families about those mitigation layers and that they'll allow for safe schooling, but also making sure we build trust. So you can create a process of co-design with teachers and staff. For teachers that are worried, have others sometimes film the classroom setup and show routines. That's something that teachers have said have been helpful. And the goal is to have a calm, even if potentially still wary, teachers and families who have a sense of control and confidence that the school is a safe environment for themselves and for their children. Next slide. So community is extraordinarily important. It's something we don't talk about in guidance very much, but I think this, you know, having a health pledge to community safety, positive messaging, caring for each other, compassion and not contention, we're in it together. So there's positive reinforcement for masking and school rules. They're sharing with each other about stresses and successes. We're actually working on a social emotional curriculum for kids coming back into schools to talk about COVID-19, community engagement, commitment to not come to school with symptoms, supporting staff not to transmit by mistake when they're in the break room. Next slide. And just to finalize a final message, which I think our way forward is, if you want to go quickly, you can go alone, or if you want to go far, we go together. And so that's the hope, and that's the goal of the work to get schools safely reopened. And that's it.
Thank you so much, Dr. Bardock. And as usual, I want hours with you and the rest of our speakers to have questions, and we have lots of questions from the audience. Dr. Gutierrez and Dr. Noble, if you want to pop back on, we'll ask a few questions. Naomi, if I can start with you, you talked about your role as a forecaster. What % of high schools do you think will be open this spring? I realize this is an absolutely impossible question, but how hopeful are you that we can get middle and high schoolers in California into in-person learning this spring?
That is a really good question, and I don't have the numbers off the top of my head. They actually just, I didn't talk about this, but they're doing every 2 weeks a survey of what schools are open or what aren't open. Some of the biggest school districts are mostly just focusing on elementary schools rather than high schools, and so they didn't pivot quite fast enough, and there's just a lot of nervousness. So I don't think we're going to get we're not going to get 100%, that's for sure, but I am hoping that map is going to change to some degree. And And we'll see what happens now that the purple criteria changed, and now that there's actually that AB 86 that has actually in order to get those dollars, you have to have high schools open as well, even if you're in purple. And so that actually should be driving things a little bit to the extent people are motivated by money.
Great. And any of you can say if you hear anything about this. I've asked this basically for anyone who knows anything about vaccines on the speaker panel, because our audience is very interested. What's your best guess on timing of vaccines for children less than 16 years old?
I'll jump in just because Erica Pan, who is our state epidemiologist, who's also a pediatrician and also an infectious disease expert, just sent me a little note. She said, maybe as early as late summer and early fall, we might be getting the 12 to 15-year-olds. The younger kids, it's going to be probably not until early 2022 would be my guess, or what I've sort of heard other people say.
Yeah, okay. And the question of high schoolers, while we're on it, I'll just stick on for 1 minute. In the early stages, when we were looking at this data, there was sort of a sense, and maybe some of the data was directionally saying high schoolers are a little bit harder to get back into school. Maybe they spread more, et cetera. And it's been really reassuring in many ways to see these latest studies that Dr. Noble presented that really suggest that in real school settings that have been able to open, and like North Carolina, where there wasn't a whole lot of financial of money put into the schools, that there is some data that suggests that you can open these schools, that the transmission, even at the high school age, hasn't been perhaps as much as we had expected, which is very exciting, and that data seems to be growing, and that's sort of what I see happening. I'd love to hear all three of you just briefly comment on, are we at a place where we can pretty reliably say, we really can open schools K to 12 right now? As long as, of course, we get through the hearts and minds issue, but from a science point of view. Dr. Noble, why don't you talk? I think I'm pretty clear on your point of view on it.
Yeah, I mean, right. Yeah, I mean, I think that the amount of data that we have on this is really overwhelming. I mean, I never thought, back last summer that we would have data sets of 100,000 people, showing that, 90,000 kids and 10,000 teachers followed for weeks at a time, and in other studies months at a time, and just not seeing what we were physiologically worried about, that middle schoolers and high schoolers with, a greater capacity perhaps to acquire and spread COVID, that, assuming that we would just see higher levels in those grades. And in what we look to now is our best designed studies, we haven't seen it at all. And in North Carolina, there wasn't a higher prevalence at all. And in Wisconsin, it was actually higher among the younger kids. Similar data from Georgia as well. So I think that getting rid of the 6-foot requirement, which was really the biggest impediment to getting middle schoolers and high schoolers back to school, with that now behind us, I think the policy regulations that have kept kids out of school are essentially gone, but now we have all of the hard work to do in reassurance. I think the year of school closures has really taken a toll on people's confidence, and the longer they're out of school, the more fearful they are to return. Speaking, mainly of the teachers, but certainly of students as well. So that's, sort of my summary, I guess. That the data is incredibly reassuring that we can do this safely, and now the question is really, how do we build back confidence?
Dr. Gutierrez, why don't you weigh in particularly with your understanding of these vulnerable communities?
Yeah, is it possible? Absolutely, right? Again, the evidence is there. It can happen, and it can happen safely. But I think the places that we're still missing is having those critical conversations with those communities to be able to build that confidence and that trust in the data that we're putting out there, right? The information changes so quickly, right? And we are having kind of our own struggles to kind of keep up with the data and decide on what we think is the best way to move forward. So I can only imagine what these communities are trying to understand with all this information. And so that link needs to be there, right? We need to have that liaison in the community to be able to look at that information, understand the plans, and make those connections to be able to talk to our communities about the safety and the confidence in that safety that we have to open up these schools, right? I mean, vaccinations next April 15th, right? Vaccinations will open up, right, to 16 and above. Are we having conversations on what we're going to do with 16 and 17-year-olds and trying to see if we can get them into high school? You know, at this point, I'm seeing a lot more requests for physicals to play sports because we can do that now than to go to school. You know, I think it really depends on the community that you're talking to, and to get that information out there and to be able to act as a liaison to make clear what that information means, and to provide confidence in the community that we're doing the right thing.
Thank you. And Naomi, how about you? How do you want to weigh in on that one?
I would just note two things. One other really important piece is the stable group piece that creates a ton of structural limitations for high schools and middle schoolers to come back to school. So that's actually why part of our thinking for the fall is that we want schools to be able to know that the stable groups, they're not a requirement now in the guidance, but a lot of people are sort of focusing on them a little bit. And so helping people get over that hump actually is going to be an important one for getting kids, the middle schoolers and high schoolers, in a robust, meaningful curriculum and you know, people in seats. So that's one piece. And then the other really important one to point out is that the outbreaks we do see in the middle schoolers and high schoolers are in the youth sports. So helping youth sports be a safe environment is actually like a super crucial part about actually the middle schoolers and high schoolers actually participate in school. Because if youth sports give middle schoolers and high schoolers a bad name, then it's going to be hard to get everybody's confidence up. So, so that's actually a really important piece of some of the work that we're also having to do on that front.
That's a really important point, and I won't go deep into youth sports because that's a big question, and I'm hoping that we can do a whole session on that. And speaking of whole sessions, I will note that we did have some questions about just kids and what happens when they get COVID and how much long COVID they get. And in context of that, I'll just say our next session, which is April 13th, that's our next monthly session, will be on what is called by various terms. I'll call it long COVID right now, and we'll talk about the terminology, but we'll address both adult and sort of what data we know about youth and the longer COVID symptoms rather. But a lot of people are really asking, and I don't know that we have the expertise in any way, either as a sort of pediatric community or here, what can we expect to happen with the mental health of our children and teams over the coming months and years? You know, I know that we're super early on gathering this data, both Naomi and Jean and even you, Raul, in some of your presentation allude to the early data that we have that talks about mental health in the time of COVID in kids. You know, one questioner said, how do we know that this is a new mental distress and not just noticed by the parents because their kids at home? You know, having seen the data myself, we are seeing in the emergency room younger children, sicker children. Jean, you presented that data about more kids needing to be hospitalized, et cetera. So I do think it's real, but you know, maybe Raul, can you just comment on, if you have an opinion on it, on thinking about the mental health of our kids over time? Certainly we're gonna have to do a lot of studies about that. And also how we think about this pandemic in the context of what we know about adverse childhood experiences. Is this pandemic going to be an adverse childhood experience for all kids, for some kids? What elements of resilience are important? How does that complex web look?
Yeah, well, you know, I think that certainly the one thing that the pandemic did do is really expose the amount of inequity that there is in the systems that we've built around children, particularly school. And, you know, I think we rely so much on our school system to provide the structure, support systems, for kids that they're just not getting anymore. And I think that's only one layer, right? I think there are probably multiple layers here in terms of why we're seeing more mental health concerns with children, right? School and the support system is certainly one of them. Being able to socialize with their friends and so on and so forth is another one. And our kids who are living in communities of colors, again, have experienced this pandemic differently, right? In terms of economic insecurity, food insecurity, housing insecurity, right? All these things are being layered on top of each other. And again, one of the things that I feel like this pandemic has done is really expose the ways and those social determinants of health affect children and families.
Yeah, I guess we're running short on time, but maybe all of you can briefly comment, but I'll start with Naomi. I think a lot of us are out here as physicians, of pediatricians or other, as parents, as community members who really want to help us spread the data, as we said, to sort of help people understand what is going on, change the hearts and minds. Naomi, do you have any sort of concrete suggestions about how we might help our kids in California?
Yeah, that's an interesting question. The thing I'm most worried about right now is the equity question, honestly. And so as much as this data can be shared and people can talk about their feelings about going back to school with communities of color, and also actually sometimes with teachers and staff, I think that would be really helpful. So the extent people know teachers and staff, actually, because so many of them are vaccinated, actually now they're turning to a role of being trusted messengers. And some of them still are worried on behalf of their students and on behalf of their students' families. So helping them to understand those safety mitigations are extremely effective, and what to sort of ask for a school, but to say that it is possible, and encouraging those family members to get vaccinated. I think all those things actually are super. That would be where I'm most worried about our schools and the equity piece.
And Raul, how important is it that the messengers from the physician side reflect the ethnicity, skin color, et cetera, of the communities that they are engaging with?
Yeah, I know. I think it's really, I think it's extremely important. I think I would almost say that it's critical to get that message across. We've seen this with vaccine access to information and strengthening confidence in getting the vaccine in our Black communities as well as our Latinx communities. I want to invoke Rhea Boyd in particular with the work she's doing with vaccines in the Black community as an excellent example of how that I think is a critical piece. The other thing that I think is really important, and again, I want to highlight, is the Pediatric Advisory Task Force in Oakland and how they partner with Oakland Unified School District to really talk to the community about what is the school plan and why are we making these decisions, and why do we think it's the right decision to make at this point in time. Those messages need to be heard, and we need to help get those messages across. I think it's great that the state is providing money to our school districts, but it's, again, money that's conditional for communities of colors to do. That's something they might not be ready to do. And it would be really great to have that money to build infrastructure, again, to gain confidence and make sure that all the safety mitigations are in place, and to maybe even fund some of these partnerships to strengthen them and have them there in the case that something doesn't go right. Right? We need infrastructure there to help support and let that community rebound.
Yeah, thanks. And finally, in the last minute that we have, Dr. Noble, you have done so much writing, and you've been interviewed by the media many times about the data, and I think have stayed really clear on the data. Do you want to talk about that experience and how others might add to the voices of kind of science and data and help us with this path forward in a broader kind of media context?
Yeah, I do think, sharing the data as broadly as possible with communities that are most hesitant, very similar to what we've done with vaccine hesitancy. But what I do think is the most impactful is dialogue with teachers unions about the safety data, because I think the quickest way to get kids back in school is to lead by example. And I think we can talk until the cows come home about schools being safe. And if kids are not back in the classroom, that talk is only going to go so far. So if we can convince teachers that it is okay and safe to reopen schools, kids will come. We know now that, at least half of children in basically all districts are ready to go back to school. And that's a critical mass that will certainly be leading by example. So if we can get the schools open and the kids back, I think the rest will follow.
Yeah, I think you're right on that. I know in parts of the Bay Area that once some kids were back in school, it was much easier to open the schools for the middle schoolers and the high schoolers. And finally, Naomi, just so we can all kind of anticipate, do you have a sense of when your group at the state or any is going to be able to give us all recommendations about what the fall might look like so that we can begin to win the hearts and minds about the fall if everyone isn't going to be back in in-person school in the spring, realistically?
I've learned in this job over the last 4 months that it is a really bad idea to say, I think it's going to happen by XYZ date. So I'm going to defer and say, we are working hard. It has been the topic of multiple meetings for me today. I have been working on documents, but when it's going to happen? Soon. Just don't know. So
yes, well,
hopefully that helps a little bit.
Thank you for your honesty, and mostly thank you to you all for your tireless work in so many arenas of this really important thing to begin to get our kids back on track to a normal childhood. Just to remind everybody, this conversation will be posted online. You can view it and send it to your friends on YouTube. We do have some other webinars in this series, and the CMA has lots of other great content that we would love you to see over time. So thank you to everyone, and we will say goodbye until April 13th when we talk about prolonged COVID syndrome.
Thank you. Thank you, Dr. Knoll, for organizing us all, and great to see everyone. Thanks, guys.
Thank you all.